I'm here with my good friend, Boris Malyugin. Boris, you gave a very, very interesting talk on something that I thought would be very challenging, maybe not in your hands, which is combining MIGS and MICS. Now, with MICS, with micro-incisional cataract surgery, we're working through wounds that are very small. With MIGS, we need space to do what we've got to do. How do you combine the two?
Definitely combining MIGS and MICS is a very hot topic right now, and it will stay with us in the years to come, because we as a surgeons are very much attracted with the concept of having additional benefit of IOP lowering effect to our patients, the one that we have from cataract surgery and the other one that we have from MIGS surgery. The challenges are many. They are related to the fact that these are two surgical procedures, so we are actually doubling the trouble that may have occur during these procedures. But by meticulously selecting your patients, I think, and doing everything properly from the technical standpoint of view, I think it's possible to avoid all these troubles and have very good effect.
So what are the special considerations that we have to take when we're doing MIGS as opposed, when we're doing MICS with MIGS, as opposed to when we're working with a wound that's slightly larger and we're doing coaxial phaco?
First, I would like to start with the patient selection. First, we have to identify who is the ideal candidate for this procedure, and this is definitely a patient with visually significant cataract and IOP, which is slightly higher or close to normal on maximum medications. Second, we have to identify these technical issues, which I don't think is a big issue, because actually with all these mixed procedures like iStent and the others that are coming, all of these handpieces fits very nicely through the small sub 2 millimeter incisions. And of course you have some restrictions with manipulation, because with smaller wounds you have access to the limited portion of the Schlemm's canal, but that can be also addressed by utilizing paracentesis incisions to access the other portions of the Schlemm canal that are not accessible through the main incision.
So it's not, I know, you're the wrong person to ask this question, because you're such a skilled surgeon.
Thank you.
But the technical challenge of doing MIGS through an incision that's smaller isn't substantially higher than it would be doing MIGS in a more conventional coaxial phaco setting.
I absolutely convinced in that, because there are different other challenges that, from my point of view, are more significant. First of all, as a cataract surgeon, we are not very much familiar with gonioprisms and how to deal with, how to know the landmarks of the anterior chamber angle and the Schlemm's canal intraoperatively. So this is more challenging for me as a cataract surgeon than dealing with the small sized incisions through the micro-incisional cataract wound.
Plus the issues of having to actually rotate the patient's head, rotate the scope, so that when you use the gonial lens you get the view that you need to get the access that you need to do the procedure.
Definitely, and we should not forget that these patients are having glaucoma, and this is causing additional issues like zonular weakness, like small pupil issues, which you have to address as well during this procedure, and maybe sometimes change your plan if the surgery going too complicated. So I may recommend abandoning the second procedure for not complicating the life of the patient and the life of the surgeon even more.
I mean, plus we expect that the patient is going to get some reduction in pressure just from the cataract surgery anyway.
Absolutely, absolutely.
Yeah, this is great stuff, Boris. I want to thank you very much for bringing this to us and for being so generous with your time with us today.
Thank you very much.